Hi, everybody. Thank you so much for having me at the summit. It's a pleasure to speak with you all today. I'm a cardiologist at Mayo Clinic, so I'm going to be coming at my presentation from a bit of a different perspective than many of the other speakers. I take care of patients with cardiac disease, and I run our ECG and physiologic monitoring lab, which handles essentially all of the clinical data that's time series data around physiologic heart monitoring and so forth. And we have been archiving our data at Mayo Clinic for several decades now, and we've realized that we've been sitting on top of essentially a treasure trove of high quality, consistent, well-labeled data. And some of my colleagues had the insight that if we could work with some data scientists, we could really unlock a lot of information that's essentially hidden in plain sight in this ECG data. And I'd like to tell you essentially the story of how we've been doing that over the past couple of years. So the title of my talk is How Smart is the ECG? And I think you'll see that it's smarter than we thought. And I'll teach you some lessons from advanced ECG analytics. The work that I'll present is funded by various sources, including NIH and benefactor funds, and some of the technology that I'll talk about today has been disclosed or patented by Mayo Clinic, and we're in the process of trying to bring this to market in various fashions. So first of all, what does the future of ECG interpretation look like? The ECG is really one of the most well-established and oldest parts of cardiology. It's the electrical recording of heart activity. And it hasn't really changed much at all in about 100 years. But what we're seeing is that by applying some of these technologies to the ECG data, we're really learning a lot more from this relatively humble modality. And let me just give you a case example to illustrate this. This was a 35-year-old man who presented after his sister had died suddenly. And he underwent an ECG. He was worried about his heart. And it was actually read by our cardiology team as a normal ECG, and it was essentially uninformative. This looks normal. But when we took some of the models that we developed over the past couple of years, it actually demonstrated that it thought that he had poor heart function and that his heart muscle was weak, gave him a 76% probability of having a low ejection fraction. And then we went on to do the gold standard test, which is an echocardiogram or a sonogram. And it, in fact, confirmed that his heart function was very poor, and he went on to be diagnosed with a familial cardiomyopathy, which probably explained his sister's death, and then other people in his family were screened. And this is an example how new technology applied to an old modality can yield new insights at the point of care and make a big difference in patients' lives. So taking a step back, when we think about applying AI technologies to ECG interpretation, there's two basic goals that we're trying to reach. One is to streamline human capability. Can a computer read an ECG as well as a human? And if we're able to accomplish that, then we can do better first-pass interpretations. We can triage ECGs based on the likelihood of abnormalities, and we can scale the work that we do. At Mayo Clinic, we read about 400,000 ECGs a year, but that takes an army of technologists and cardiologists to do so. And if we could leverage AI, we could do that more effectively at lower cost and at scale. That's kind of the obvious application of AI to the ECG, but the more interesting one, in my opinion, is actually to go beyond human capability. And these are the kinds of things where an ML algorithm or AI trained on ECG data can actually see beyond what a cardiologist can see. And in that sense, it's adding new value to the ECG. And it moves beyond this ECG is normal, this one is abnormal, to something that is much more richly informative. So if we talk first about doing what we do on the cardiology side, scaling human capability, we're essentially asking whether our technologies can pass the Turing test. Can a cardiologist look at a read that is done by the AI and tell it from the read that is done by an expert cardiologist? And we just recently completed this study where we use standard ECG interpretation software, our AI algorithms, and then the ECG lab read, which is a combination of our technologists and our cardiologists to read it. And essentially, we've asked expert cardiologists to say which of these reads was correct in a blinded fashion. And what we're finding is that our AI can get it right about 94% of the time, and it gets all of the codes right on an ECG about 85% of the time. So this is better than the state-of-the-art analog kind of ECG software, but it's still not up to the point where we can rely completely on these technologies. We still require some human oversight. And this is something we're going to continue to work on and refine. But I think the more interesting examples that I'd like to show today are where we can see beyond human capabilities on the ECG, and I'll give you 3 examples. The first example is the example that I showed in the opening slide about detection of low ejection fraction or a weak heart muscle. The ECG is basically designed to tell us about heart rhythm. What's the heart rate? What is the nature of the rhythm? What kind of abnormalities are there? But it's not a test that tells us much, at least we didn't think, about heart function. But by taking a large data set at Mayo Clinic of people who had paired ECG data and echocardiography data, the echo is what tells us about heart function, we could train a convolutional neural network to pick up the signature on a normal 12-lead ECG that correlate well with abnormalities of heart function by echocardiography. And it took about 100,000 ECGs to train, but a very rich data set we could do that. And we can see very good test performance both in the validation and testing data sets. And we achieved an area under the receiver operator curve of 0.93, which in medicine is very good. In other tests that we use all the time in routine clinical practice, maybe a pap smear or a mammogram or PSA testing for prostate cancer, typically have AUCs in the range of 0.7 to about 0.85 or so. So in fact, this test does better than many things that we've accepted. The next step, of course, is to validate the algorithm in external populations. And we've done that from populations around the world, and we're currently validating it in other US populations. Because, of course, the Achilles heel of many of these algorithms is that they work very well in a particular data set. They may work well at Mayo Clinic, but it might not generalize well to other populations. And that's the next thing that we're trying to evaluate. We've made these algorithms readily available to clinicians at Mayo Clinic, and groups from around our practice have started to apply and test them in various modalities. So it's been tested in the emergency department for people who come into the emergency room short of breath, and in that group it performs very well. So it's probably a good test for telling somebody who's come in with an emergency, they're short of breath, whether they have asthma or whether they have heart failure or whether they have pneumonia or what's the likely cause of their shortness of breath. And it performs better than routine blood tests for that. Our colleagues in the cardiac critical care unit have looked at it for detection of low ejection fraction in people who are hospitalized with severe cardiac disease, and it performs well in that situation, and even more so, it actually correlates well with hospital mortality. So it's not only diagnostically important, but it's also it carries potential prognostic value. We have to be cognizant of the risk of perpetuating or creating bias in medicine, and an algorithm that is trained predominantly in a Caucasian population, for instance, may not generalize well across other demographics, racial or ethnic subgroups. So we've performed analyses looking at various racial and ethnic subgroups, and the AUC is remarkably consistent for this algorithm. So we're really starting to get a lot of confidence that this algorithm can work well and that it may be broadly applicable. If we take a step back just for a moment and go on a bit of a detour, the algorithm performance was excellent. And we thought, well, perhaps we could improve the model further by just adding a few simple demographics. What if we added age and sex to the model? Could we go from 0.93 to 0.99? And the answer was no. And in fact, it didn't improve model performance at all, which for me and the other clinicians working in this field was a bit of a head scratcher. But our data scientists said, well, that's not surprising because it's likely that the convolutional neural network already knows what it needs about age and sex just from the ECG. So giving it structured data about age and sex probably is not increasing model performance. And indeed, we were able to then demonstrate that a separate convolutional neural network was exceptionally good at determining the sex of the patient by the ECG, something that most clinicians would not be able to do, and was able to estimate the age of the patient within about 7 years across a broad range of ages. So we don't think of the ECG as telling us much about age or sex, but this is, I think, proof that there's something in the ECG that we don't see that a model like this can see and could be informative. And that's led to all kinds of interesting questions. If it's telling us something about age, is it telling us something about physiologic age? Does it tell us about frailty? Does it tell us about risk of mortality and so forth? And if it can tell us about sex, does it tell us something about hormonal status or something? So we're doing a lot of work to try to unpack that and learn more about it. We found some interesting cases where there were patients who didn't seem to fit. This patient was a lot older than his stated age. At the age of about 30, he looked like he was about 55. He got older year by year, and then dramatically and almost overnight, he seemed to get much younger. And when we dug into this chart, we actually found that he got a heart transplant on that day and indeed got a heart of a younger man, and that explained the change in that model output. So fascinating to me that the model could pick up that he had received a new heart. Anecdotal, but kind of fun. The second example I'll give you is hypertrophic cardiomyopathy. And for those of you who don't know about this condition, this is the reason why you'll sometimes hear a dramatic story about a basketball player who collapses on the court, or a soccer player. And this is a cause of sudden cardiac death, and it can be particularly problematic in young people and in athletes because some of the arrhythmias are associated with exercise. The trouble with this disease is that while it often results in an abnormal ECG, the ECG can be abnormal in many different ways. And the problem is a problem of increased thickness of the heart muscle. So the voltages get high and there are all sorts of different abnormalities. But most cardiologists can't look at the ECG and say with certainty that this is hypertrophic cardiomyopathy and this is not. And because of that, the recommendations for screening for hypertrophic cardiomyopathy with ECG are somewhat inconsistent. We have a large referral population at Mayo Clinic of patients with hypertrophic cardiomyopathy, and we created a paired database of hypertrophic cardiomyopathy patients and age and sex match controls. And just like the first example, trained a separate convolutional neural network to pick up the ECG signature of hypertrophic cardiomyopathy. And this model performed even better than the low ejection fraction model with AUCs in the range of 0.96. Also, you see that there's very good separation of model output based on low or high outputs based on the cases and controls. So it really comes down quite definitively in favor of or against a diagnosis of hypertrophic cardiomyopathy. The model performed quite well across a wide range of subgroups, and particularly well in young patients, which is reassuring to us because those are the patients we want to actually screen for. And it performed well whether or not the ECG was normal or abnormal. So some patients with hypertrophic cardiomyopathy have a relatively normal ECG, and it still worked in that population. Shortly after we developed this model, I was rotating on the clinical service, and I was seeing a young woman who was admitted for surgery for hypertrophic cardiomyopathy. So a surgeon was actually going to take out some of that thickened muscle because it was essentially choking out her heart and impairing her heart function. When I looked at her ECG, it did not look all that dramatic. In fact, the ECG lab called this as a normal ECG, but when we turned our AI model to this, it actually gave her a 72% probability of having this rare disease, which is a diagnostic odds ratio of several hundred-fold. The next day when I rounded on her after her surgery, I was fascinated to see that even though now, after her surgery, her ECG looked more abnormal, to the model, it looked less like hypertrophic cardiomyopathy. So removing that abnormal heart muscle actually made it look abnormal, but less pathognomonic of hypertrophic cardiomyopathy. Another anecdotal but powerful example. The next example I'll give is atrial fibrillation, and this is a problem where the heart rate goes often fast and irregular. The problem with the disease, however, is that it's often fleeting, and patients may have this lasting for only minutes or hours. They may not feel it, and by the time they come in to get it checked out, they're often back in normal rhythm. So the diagnosis can be very elusive. And atrial fibrillation increases the risk of stroke probably about 5-fold. So it's a diagnosis that is very important to make, but can be very challenging. In people who we think might have atrial fibrillation, for instance, people who have had a stroke that we can't explain, we sometimes go as far as implanting a device under the skin that monitors the heart for about 3 years looking for the diagnosis. And that can be expensive, and it's somewhat invasive, and it carries some modest risks. So if we could pick up a signal of atrial fibrillation risk on the ECG, it could be very powerful. And that's exactly what we did. We created a data set of patients who had both atrial fibrillation and sinus rhythm, and a data set of people who had only sinus rhythm. And we trained the model to pick up the signature of atrial fibrillation that was present in the normal sinus rhythm ECG. So even when AFib wasn't present, it could still pick up a propensity towards atrial fibrillation. Here, the AUC is about 0.87. We then took this model and applied it to a large data set at Mayo Clinic, the Mayo Clinic study of aging. And this is a group of patients who are very well characterized over more than a decade. And we have well adjudicated atrial fibrillation events in this group. And the model performed well in terms of predicting the likelihood that these patients go on to develop atrial fibrillation. And even more so, if the model output was very high, they were actually at higher risk of stroke. So not only are we predicting the arrhythmia, we're predicting the consequences of the arrhythmia, the actual stroke. Shortly after we developed this model, one of our neurologists came to us and said, would it have been useful for this patient who has been plaguing me for the past 12 years or so? This was a woman who had been followed at Mayo Clinic for a long time, and she suffered a stroke in 2014. At that time, she was in normal sinus rhythm, but this is the model output for the likelihood of atrial fibrillation. And you can see that the model output was very high. This is the threshold for a positive test. Even though this patient was had a stroke at this time, they were in normal rhythm, and the neurologist couldn't justify starting an anticoagulant. A few years later, she came back, unfortunately, with her second stroke, and she was still in normal sinus rhythm. And he had very high suspicion of atrial fibrillation, but couldn't diagnose it. And it wasn't until a few months later that she came back with atrial fibrillation. So the question there was, could we have picked up AFib earlier? Should we have been screening her before her first stroke? Should we have been treating her empirically with a blood thinner at the time of her second stroke? And these are the kinds of questions we'd like to go on to answer prospectively. So not too long ago, Nature Medicine editorial board came out with a editorial on the need for randomized and prospective clinical trials evaluating these kinds of AI technologies. And they really believe, and we believe, that these kinds of technologies need to be held to the same standard as all other diagnostic and therapeutic interventions that we use in routine clinical practice. So the next stage is not just to develop the algorithm, but to find ways to test it prospectively. So just 2 weeks ago, or it may have just been last week, we published our first clinical trial for this, and we published it in Nature Medicine. The trial was called the EAGLE trial, which is ECG-guided detection of low ejection fraction. And essentially what we did was we made this algorithm available to primary care physicians at Mayo Clinic. And we deployed it across the upper Midwest health system, which included about 40 different clinics and hospital-based practices across the upper Midwest in Wisconsin and Iowa and Minnesota. And care is generally delivered by care teams, so groups of doctors working together. And we essentially turned the report, the AI report, on through our electronic health record for these care teams in a randomized fashion. So half of the care teams got the report, half of them didn't. And over a relatively short time, we performed the AI algorithm on over 32,000 patients, and then we reported in a randomized way whether the AI result was positive or negative, and then we suggested that clinicians obtain an echocardiogram, or the gold standard test for low ejection fraction, if the test was positive. What you can see here is that the study was performed in a wide variety of clinical settings, including mostly rural patients. So these were not patients being seen in subspecialty cardiology clinics, or they were not being taken care of by doctors who were enthusiasts or early adopters of AI technologies. This is real-world practice across our health system. And most of the patients were in the outpatient clinic. Our primary finding was that the intervention increased the diagnosis of previously unrecognized low ejection fraction with an odds ratio of 1.32. So we diagnosed about 30% more patients in routine practice with undiagnosed low ejection fraction. That's a condition that can progress to heart failure and can be very important to diagnose. And these are patients that are probably slipping through the cracks of our everyday practice currently. The reassuring thing here was that we didn't end up ordering a ton more echocardiograms. So if we had, because clinicians were given the results and they could integrate that with their clinical gestalt and order an echo if they thought it was valuable. So we don't think that deploying this technology is likely to increase healthcare costs all that much, and we're likely to pick up a lot of new cases. You can see that the model performed particularly well in the outpatient clinic, which gives us some clues about how this could be deployed. And it may be particularly valuable in patients who are not in the hospital, because if you're in the hospital, echoes are relatively accessible, and we probably are not missing nearly as many cases there. But in the outpatient setting, it can be hard to know who to work up and who to refer to cardiology and so forth. And in those patients, these kinds of technologies may improve our clinical care. Once we diagnosed a low ejection fraction in the study, 97% of people in the intervention arm were appropriately treated with ACE inhibitors or beta blockers. These are the drugs that are proven to improve outcomes in these patients. So not only were we making a difference with diagnosis, but we were getting patients on the treatments that they needed. Looking at this another way, for every 1,000 patients that we make this kind of AI technology available to, we will pick up about 5 new cases of previously unrecognized and potentially dangerous low ejection fraction. Now that may not seem like a lot, but at a health system like Mayo Clinic, where we do 400,000 ECGs, very easily we could pick up hundreds, if not a couple thousand patients a year who otherwise would have slipped through the cracks and eluded diagnosis of low ejection fraction. So I think very encouraging that these kinds of technologies could be deployed at low cost and at scale to the benefit of our patients. The next study that I'll mention is evaluation of patients with atrial fibrillation. And the logical extension of creating an algorithm that can pick up AFib risk is that maybe we should be deploying this in order to screen. But current guidelines actually don't recommend screening with an ECG. And the reason is diagnostic yield is relatively low because their arrhythmia can be fleeting. And we don't really know how to treat screen-detected atrial fibrillation. So we'd like to try to build out our evidence base around these kinds of questions. So this next study, the first was Eagle, the second is Beagle. Sort of cutely named, but it's sort of the next test, the next trial along the sort of life cycle of evaluation of these algorithms. What we're doing is using structured and unstructured data from the electronic health record to identify patients in whom AF screening would be valuable. So if we were to diagnose atrial fibrillation, they would be at sufficient risk of stroke because they have other risk factors that we would actually want to anticoagulate them. So we first start by identifying the key patients. We then apply the AI algorithm to any existing ECG that's already been done on that patient. So we're not even asking them to come in for an additional ECG. Most of these patients at high risk have had an ECG for one reason or another. We apply that AI to retrospective data and identify patients who we think are at risk of atrial fibrillation, and then send them a cardiac monitor that they can wear for 30 days to make a definitive diagnosis. The monitor looks like this, and one of the first patients that we hooked up was a retired Mayo Clinic doctor who had diabetes and hypertension and chronic kidney disease, so we wanted to know if he had atrial fibrillation. If you look at his model output over the years, for a decade, he's looked like he's been at high risk of atrial fibrillation, but every ECG, and he had over 30 ECGs at Mayo, showed normal sinus rhythm. But shortly after we picked up and hooked up the monitor, he actually went into atrial fibrillation. We called him up, put him on a blood thinner, and he's getting the treatment he needs. And hopefully this patient, we've reduced his risk of stroke and maybe even prevented a stroke. Stat News actually just recently profiled this, and they found another patient from our trial. This was another retired Mayo Clinic finance executive who enrolled in the trial. He had always been in sinus rhythm, but had some palpitations. He looked like he was high risk. We sent them the monitor, and indeed he was diagnosed with atrial fibrillation. And if you want to read more about this, you can read this stat article by Casey Ross, and I think it gives a very balanced look at the upside and the potential downside of these kinds of technologies and the feasibility of rolling them out at scale. In addition to doing these sorts of clinical trials, we want to find novel ways to get these algorithms to the point of care. And we've created a dashboard within our electronic health record. So this is my de-identified database. I've had one ECG, and you can see that it could tell that I was male. It doesn't think I have atrial fibrillation. It doesn't think I have hypertrophic cardiomyopathy or low ejection fraction. And it got my age more or less correct. So this is now available to Mayo Clinic clinicians, and they can look at these kinds of data and start to explore it with the patient and figure out how these things might be applied while we work towards it. So it's there at a single click within Epic, and it'll pull up this dashboard. My data wasn't all that interesting, but there are other cases like this patient who had heart failure in the early 2000s. He then had a heart transplant, and his AI for EF, normal ejection fraction, actually normalized. He did well until he came back at the end of last year with rejection of his transplanted heart, and the AI actually picked that up. So we think about maybe we could screen patients for transplant rejection with this kinds of technology. And there's lots of very interesting things that we're going to start to work to test going forward. We were working for quite some time with a company that makes this very interesting stethoscope that contains these two metal plates. And because of these two metal plates, it can record a single lead ECG that's displayed on a smartphone. And we found that we can actually deploy the AI algorithm on that single lead ECG, and then use the stethoscope to actually detect the likelihood of low ejection fraction. And this is a technology that's under development, and we're enthusiastic about the capability of deploying these algorithms with the sort of edge computing approaches at the point of care. So I think what you can see is that we've known for a long time in medicine that we provide the best patient care when we leverage multiple specialties and we all work together around the needs of the patient. But what you can see is that there's probably a role for the AI engineer, the computer scientist, the data scientist in direct patient care. And we now work very closely with our engineering team, and they've helped us look at some old problems in new ways, and I think are really helping us provide better care at Mayo Clinic. So I think you can see that there's clinical utility. I think you're seeing that we can predict and detect disease, that these kinds of technologies are scalable, and that by working together, we're able to drive practice innovation. And it's been very exciting to me. So I'd like now to hand it over to Roger, who's going to present the next part. So Roger, over to you.